All right, let's get started. Good afternoon, everyone. So today for our GHP Brown Bag, it's a great pleasure to have Professor Justice Nonvignon, who is a professor of health economics and policy at the School of Public Health at the University of Ghana, and also the head of the health economics program at the Africa CDC, which is based in Addis Ababa, Ethiopia. And so great pleasure to have Justice with us, who is going to tell us about how he sees the role for the Africa CDC in terms of informing post-COVID-19 reforms. So over to you, Justice. The floor is yours.
Thank you, Stefan. I hope I'm loud and clear. Great. So thank you, and thank you, colleagues, for taking some time off your busy schedules across different time zones to be part of this conversation. So really, it's about placing health at the center of the economic agenda of countries, really. And what I want to share with you is what the Africa CDC has done, what the Africa CDC is doing, or how the Africa CDC, particularly the Health Economics Program, sees itself playing, some role to push health onto the agenda. I will start off. Okay, one second. Slide. Okay, great. So I will start off by simply reflecting what we've seen over the past 2 years and what implications that has for all of us who are in health as we seek to push the agenda for health, particularly very high on countries' agenda. And then I will share briefly what the African Union, Africa's response to not only COVID-19, but health security threats has been, and then say a few words about Africa CDC and focus really on the health economics program at Africa CDC and what reflections based on the work we've done in the past year or so we see about this topic. I do not want to bore you, colleagues, with what we all know as the biggest challenge of some of us who are young enough, our time. And it's really not to underestimate the issue to call these two different things beasts. But if you look at it, in many ways, it's plays out that is being a challenge of health and the economy, right? We know that for those of us who are into health economics, we've always known and into health. We've known that health is very central on development agenda of countries, but really it has taken COVID-19 to expose the fault lines within our economy, and in a very short time we've seen what impact health can have on the economy. Within a matter of months, we see that if you lock down your country, if people do not work, you can see that immediately affects your economic output in terms of lost or reduced gross domestic product wealth of the state, essentially. So essentially, this is where we find ourselves, that now we really do not need anyone to tell us that there is a very clear link between health and the economy. The way we bridge these fault lines will really tell us where we can go from here. So I pulled these slides from one of the World Bank publications that essentially focuses on the affordability of COVID-19 vaccination, high vaccination rates, picking the 70% coverage. That is what we've been working with, and determining whether, based on each country's current health expenditure levels. Vaccinating 70% of their population is something they can afford to do. If you see on this slide, I mean, for most of the countries, I mean, essentially all the countries on my left, from DRC to Mali, and part of the countries on my right, it is difficult for them to afford domestically to really vaccinate their populations, which means that something else needs to be done. For some of the countries really below, if you look at Seychelles, you look at Botswana, I mean, those that are high up in terms of the middle income, space, it is affordable. For some countries, if you look at the per capita, spending on health, it is quite difficult to say we leave these countries to vaccinate. So essentially, what we are saying is that if you pick COVID-19 alone, which is just one pandemic, just one public health threat, and we are dealing with several of these on the African continent, I mean, on a daily basis, it is really exposing that we need to do something extra to afford, to take care of our health and essentially to get us to the economic output that we want. So what has been Africa's response, not to COVID-19 specifically, but to health threats generally? We see this in the past couple of years, starting with the creation of the Africa CDC in 2017, which is, has just gone through a baptism of fire, has to deal with health threats such as Ebola, more visibly in the COVID-19 space, but also many other health threats across the African continent. But we also see this, in the creation recently of many other agencies to respond to together respond to the various health issues facing the continent. So we see the Africa Medicines Agency, for instance. We also see attempts in the creation of other platforms, such as the Partnerships for African Vaccine Manufacturing, and the AVAT, African Vaccines Acquisition Trust, among many others. So for us, this tells us that the African continent is getting ready, has identified these threats, and has taken a very bold step. We also see recently the establishment of the African, the fund, the pandemic, epidemic fund, Africa Epidemic Fund, to help the continent raise more resources so that we can prepare better for these threats. So just saying a bit more about Africa CDC, the Africa CDC has been in existence for 5 years and has managed to, shepherd the continent to face these threats. The vision of the Africa CDC is a safer, healthier, integrated and prosperous continent in which the states can work individually, but also collectively in an efficient manner to prevent disease transmission, implement surveillance and detection, and always be prepared to respond effectively to health threats and outbreaks. And as I said, Africa CDC has worked with partners to really work towards safeguarding the continent against these different health threats. The Africa CDC recognizes that economics is a key issue because we've seen this at play in many countries. We've seen the average economic output of countries significantly drop because of just one of these threats. So what the Africa CDC's response to this, is to create a health economics program. A program that seeks to serve as a trusted partner to African Union agencies and member states, and essentially a go-to resource for providing guidance to countries or member states as they go through or think through their process of leveraging health economics evidence to inform the different decisions that they have to take on a daily basis around prioritization of health and to meet the needs of the health needs of Africa. all these contributing to the overall Africa CDC vision of a stronger and more efficient health systems, healthier populations and communities. So this is what the Africa CDC Health Economics Program was created to do and to lead the charge. And we are working towards effectively playing this role. So the program works along three strategic pillars. One of them being obviously evidence generation and mobilization, really, or synthesis, pulling together the different pieces of, economic evidence around health to inform the Africa CDC itself, decision prioritization, but also to inform member states as they seek to take different steps, whether they are working towards primary healthcare or developing essential health benefits package or any other thing, to place health at the center, but also to ensure that we do that in a way that presents value for money, that is efficient. In addition to that, we do recognize that on the African continent, capacity for health economics is not a lot. So our aim is to undertake these evidence synthesis while also strengthening capacity for different entities and for different member states, capacity for the people who would help produce or generate those evidence, but importantly, capacity for policymakers to understand and be in the position to use, to understand, be in the position to demand and use health economics evidence, but also capacity for these two constituents to understand each other, to engage so that researchers understand clearly what the policy needs are and seek to tailor their question. So that's what we are seeking to do in the capacity strengthening space, of course, working with other partners. Then the biggest, well, not the biggest, but one of the key areas which is really the niche of the program, is sitting at the interface between evidence and policy. We know that there have been challenges around that, but sitting within the CDC and the African Union, how can we convene? How can we play that convening role? How can we channel the evidence to policymakers in a way that is relatively easier for them to understand and use? How can we serve as a platform for policymakers to essentially call on, hey, can I get some evidence on ABC? While we work with other partners, of course, the program is not seeking to do everything on its own, but there are networks of academic institutions, research institutions, and other policy entities, including civil society, that the program seeks to work with. So essentially, these are the strategic pillars that we work across. Each of them not seen as a separate entity, but all of these working together to achieve that common goal. And that goal is making health decisions evidence informed and preparing people to be able to do that. So that's the program. There are a couple of activities that align with these three pillars, but very high level priorities we are currently working on, very different activities in each of them. One is to help elevate the discourse on investing in what I call FELS, public health emergencies, laboratory, diagnostics, surveillance systems. We do know that historically this has been a challenge for many African countries, whether they are local or national laboratory systems and surveillance systems, or whether they are regional systems that will help all of us get prepared better. So what the program seeks to do is to bring the economic perspective to this, to raise that discussion really, because there is a need for countries and regions to invest, to be intentional in investing in the infrastructure that supports these different areas, which is really what Africa CDC is there to support countries to do. But also to bring some context to other discussions, whether they are around primary healthcare programs for universal health coverage, or whether they are around other health systems issues. To contextualize, meaning to bring to bear what the actual needs of countries are and ensure that whatever we do actually seeks to respond to those needs, not the other way around, not asking policymakers to respond to our research questions when we've already said them, but essentially to bring these two groups together and ensure that whatever we do as researchers or the academic community, we are meeting the needs of policymakers through some well-defined policy questions. And then, of course, we want to be intentional in building capacity for health economics, for financing within Africa and as close as possible to countries to help them. We know that there are many stakeholders playing roles, but we want to spearhead a more systematic way of bringing stakeholders together, whether they are Northern partners or partners in Africa, so that we can systematically ensure that we work towards a time when Africa will be self-sufficient, really, in terms of having people that will lead the generation, the synthesis, and things like that of the evidence that is required on the continent. So this is something that we've taken we've thought about a lot, and we are working with different partners to seek to achieve this. So short-term capacity, more medium-term capacity, longer-term capacity, not only for academic, for research, but also for the policy community to ensure that we actually move more towards this. Now, let me share with you briefly what the Health Economics Program at Africa CDC has been doing or working towards helping to place health on the agenda or at the center of economic reform programs. These are a few examples. For instance, we've been working over the past year to generate some and synthesize evidence around COVID-19, vaccine deployment, around the economic evaluations, costing of these different pieces, and really around issues of equity, across countries, but also within countries. And particularly, we've been working in 3 countries, Nigeria, Ethiopia, and Kenya. We have worked over the period to generate evidence, and evidence that responds to policy questions that policymakers themselves identified within each of the countries. So what Africa CDC has done is to work with the different stakeholders. So in each of these countries, we have academic or research partners, but we also have other partners such as the London School of Hygiene. We've worked with the Center for Global Development and the IDSI to ensure that each of the policy questions we address are things that come from country-level policymakers. In addition to that, at Africa CDC level, we've had virtually bi-weekly meetings over the past year to ensure that, one, the questions align, also with the continental agenda of the new public health order, but they also align with questions that the continental stakeholders are looking at. So we've generated the evidence for each of these countries, but we have also led the charge to undertake some regional analysis in terms of responding to policy questions like, okay, so what happens if we cannot meet the 70% target? This is it's ambitious, but it's something that countries are working towards. So what happens if we cannot meet that? Or what are the other interventions that can help us better meet those? So we've undertaken epidemiological, but also economic analysis, modeling and analysis to look at the different scenarios that face countries within Africa. I must say the regional piece really uses data from about half of African countries. So it takes a more regional perspective of this. And we are in the process of finalizing policy briefs and then, instituting a series of learning webinars with policymakers and with other entities to really share these findings. We also are working to explore what the cost implications of the pre-travel spending measures in the different countries are on countries, but also on people. We do know that over the past 2 years, different countries have had different screening measures. For some countries, like Ghana, until a couple of weeks ago, before you move out, you need to take a COVID test. When you get to your destination, you take a COVID test. Before you come back, you take a COVID test. Before departure, when you get to Accra, you take a COVID test. Each of these have resource implications. So the purpose of this particular work is to work with different countries in each of the African Union regions to try to understand what these implications are on resources, but also what the some equity aspects of those issues are. We have also worked and almost finalized a case study that seeks to determine from the policy perspective what the returns on investments in national, but also regional laboratory and diagnostic systems are, using Zambia as a case study. I mean, the early part of the work really was a policy review to try to understand what the implications of these different things are. We are also actually working with other partners, such as the AFIA, the African Health Economics and Policy Association, to delve deep into equity considerations as far as COVID-19 vaccine deployment are within African countries. So what I'm saying is all of these are geared towards bringing economics, into the work that Africa CDC is doing, so that we are not only targeting and speaking the same language with the ministries of health, but we are actually speaking the same language, and we are motivating the ministries of finance, who are the purse holders. We are also seeking to target the economic advisors to heads of states, particularly now that a lot of these member states are in the process of developing, their post-pandemic economic reform programs. So indeed, CDC to supporting elevate health onto the agenda goes beyond simply the social arguments that we make. Social arguments are very good, but what we are trying to generate and synthesize evidence to argue is that we also need to begin to see health as a business. We need to bring the business part, from health, and show that if you invest in health infrastructure, whether they are, health systems infrastructure or some other, health infrastructure, you are actually not just investing and not expecting return, but indeed, if you look carefully and you estimate carefully, the returns on these investments are enormous. And so we should begin to have that discussion that health is actually an economic good. Economic good that brings, that brings returns to countries. And my intention is to sort of finish this and raise a few questions that I think we can discuss on this platform. Really, that indeed over the past year and a half that the Africa CDC Health Economics Program has been trying to work towards these aims, and indeed over the past 5 years that Africa CDC itself has been going to town, leading the public health infrastructure, and surveillance in Africa. A couple of reflections come to mind as far as the economy is concerned. Of course, obviously, health is wealth, as I've said earlier on, and we need to begin to see it as such, that health does directly contribute to the wealth of nations and of individuals. And so we need to, our investment and our focus on health, placing it on the agenda of economics, of economies in Africa, is really to say that if countries really take some more time to invest, not only their resources, but if countries prioritize health in their economic reform programs, in their annual spending, there are returns that accrue to those countries. That health creates significant returns. And what we are doing essentially is to use the various health economics tools available to us, not just economic evaluations and costing, but also all the other economic tools to make this argument and place health squarely at the center of post-pandemic reform programs in countries. And as we do this, it is important for us to clearly identify who the key stakeholders are. Sometimes we leave some of them out. But for us, we are intentional at identifying who these key stakeholders are. As I mentioned, we've been very good, the health community, at engaging ministries of health. Even in terms of health economics, we've actually engaged them to, help them prioritize, priority setting, using HTAs and multi-criteria decision analysis, using different economic tools, right? But we also need to intentionally bring in the conversation, lift up the conversation to bring in the ministries of finance. And importantly, well, equally important is engaging other people like economic advisors who may not be indeed holding the purse, but they hold a very key role in where to place health on countries' agenda. So it'll be good for us to have a discussion. We were intentional, and I'm keen on hearing from all of you your experiences, on how we can do this. The other thing is that the existing environment helps us. Actually brings the ears of heads of state, very high level authority in countries very close to us. We need to take advantage of that, not only to ask for more money, but also to ensure that we get more help for the money. That the decisions we take are, evidence informed, that we use the different tools available to us to help prioritizing decisions within countries, and indeed promote efficient use of these scarce resources, because we don't have no country has every resource it needs. But how we take decisions in terms of prioritizing is key. So again, how can we do better? Sitting at a place where we are supporting not just the Africa CDC, but also the other agencies I talked about, the African Medicines Agency and the AVAT and the vaccine manufacturing, and all the entities really helping to facilitate or play a facilitating role towards discharge. And finally, of course, I cannot end but without saying this, that historically, African countries, just repeating what I said earlier on, have not invested adequately in public health emergencies, emergency systems, labs and diagnostic systems, surveillance systems. We need to intentionally push this agenda. And this is what the Africa CDC Health Economics Program is seeking to do. That countries need to, as a way of preventing the future pandemic, which would also, could also come with very significant health, but also economic implications, really take the time now and indeed urgently to invest significantly in these infrastructures. That helps us to promote not only domestic investments, but indeed all other investments in these different areas. So the Africa CDC Health Economics Program is timely, in my view. Some of these conversations are things we should have had, maybe 2 or 3 or 5 years ago, and they would have helped us to prepare better towards whatever pandemics come up. Africa is facing not just one pandemic, but several of them. The CDC publishes on a weekly basis the different epidemics happening in different places, whether they're Ebola, cholera, or any others. And you'll be amazed that there's a lot happening on the continent. While we do this, we need to systematically, elevate that discussion of how do we invest sustainably in our health system. so that we are better prepared for future pandemics. And I'm happy to have shared these reflections with you. I look forward to discussions. I'm intentionally leaving a bit more time because I know that this group here has the experience and expertise to share their thoughts on this. So I want to thank Stefan again for inviting me to present this, these reflections, and I look forward to learning from the questions and the comments that come. Over to you, Stefan. Thank you very much.
Thanks so much, Justice. Excellent. Thank you for sharing these remarks to us. So, excellent. The floor is open for questions to Professor Justice. Goodars, I see your hand is up.
Yes, thank you so much. Very interesting discussion. I've done some work in Tanzania, Uganda, elsewhere on cardiovascular disease, NCDs, and policy, and done some work with Stefan jointly on HIV and cardiovascular disease. When it comes to your second bullet point here on using evidence, we always have had to borrow a lot of evidence from other countries, and sometimes we have the empirical evidence that you can do that and you have an intervention that has worked somewhere else. There is no reason to believe that it wouldn't work in a next door country or a similar setting. Other times it's less comfortable. So how much is the African CDC equipped or ready, or is it in any of the priorities, or I didn't see it in the pillars, to sort of generate the evidence itself on what works, what doesn't work, support prospective studies or small trials here and there, in a sort of creating a public health laboratory sort of thing where new interventions can be tested, be it COVID vaccine or cardiovascular medicine. Thank you.
You want to answer, Justice?
Thank you, Stefan.
Questions one by one.
Yeah, whatever you want me to do.
Yeah, please take the questions one by one.
Sure, great. No, thank you very much for that question. I think it's, so the Africa CDC itself is actually generating evidence, right? The Africa CDC has, trials, is working with stakeholders in many cases. And the health economics program is also, as I said, a few of what we are doing. We actually are generating evidence on some of these things. But I must say that the purpose is not for the Africa CDC to itself generate all the evidence. We would never have the capacity to do that, right? But to actually, because there's a lot of evidence available, right? To facilitate, I think that's the word I want to use. To do two things: facilitate where there is a need to generate evidence, to facilitate and work with stakeholders, mainly in-country stakeholders, sometimes working with external stakeholders also, because it is very key to generate some of that evidence, but also to synthesize what evidence is available. So these days, what I do is, the other day I sent an email to say some external stakeholder, I said, I want to know what is happening as far as COVID-19 vaccine delivery costing is concerned on the continent, because I know there are many stakeholders doing different things. So I sent an email to say, can you please update me which stakeholders are doing what in which country? Because then we don't need to go repeat the same thing, right? We can work with these stakeholders, and indeed, even if not, we can synthesize or help synthesize these different evidence so that we can support decisions, country decisions, regional, but also continental decisions using that evidence. So what I'm saying is that, yes, the Africa CDC and the Health Economics Program have the capacity to generate some of the evidence themselves. But I must say that most of that evidence will be working with entities, mainly academic and research institutions and other stakeholders, those within the continent, those outside the continent, so that we are aware of what the different evidence, pieces of evidence are, And actually, we can ensure that we channel them to the appropriate policymaking quarters. So essentially, that's the approach we are taking. And is the reason for us, capacity strengthening is key, because if we have people in country, then somehow we know what the quality of evidence that people in country will generate, and those will feed directly to what we do. So just to be clear, we are not seeking to be the ones generating all the evidence ourselves. We are seeking to also facilitate the generation, and we are seeking to synthesize and be, like I said, a go-to place where countries can simply look up and get some of the evidence. So I don't know if I've fully addressed your question, but I think as far as the program is concerned, this is what we are seeking to do.
Thank you.
Great. So I don't see any hands up. So I'll have one question for you, Justice. You mentioned one of your slides, there were 3 areas regarding the priorities for priority setting. So I was wondering, in terms of, and you talked about contextualization of priority setting and the cost effectiveness studies. So how much, in terms of the kinds of studies you're planning to do, you're thinking about HTA and new technology introductions versus some of the more systemic questions that you talked about, where perhaps it's not so much about a new technical interventions to be introduced to new technology, but perhaps the delivery platforms. So maybe some thoughts from you about how you're thinking at the agency in terms of the economic evaluation questions, perhaps around health system strengthening and so on, should be incorporated in the kinds of economic evaluations you're thinking of.
Yeah, good question, Stefan. And let me highlight the recent work that we did, Stefan, you and I and your colleagues, Nathaniel and co. So when you think about economic evaluations and health economics, really, there's been a lot of focus, maybe rightly so, because of the world's push around specific diseases, specific interventions. If it's malaria, go to malaria, you have a lot of economic evaluations of malaria interventions. Go to HIV, go to TB, you have them. But if you pick the more systems questions, and if you really look at what the Africa CDC stands for, it's actually strengthening systems, right? There are the disease-specific interventions. There are the systems issues, whether they are procurements or data systems, right? Health information systems or health financing systems and things like that. They are key, particularly as we move from verticalization of programs more to integration of programs. So for us at a CDC, that approach is key, and we've only taken advantage since the program just began. We've taken advantage of questions that have to do with immediate issues, right? COVID-19, how do we vaccinate? Countries are asking, okay, we don't have all the vaccine doses. How do we prioritize? Should we give 2 doses to a few people, or should we give 1 dose to more people? Should we focus on vulnerable populations? Should we focus on health workers? Versus how can we be more efficient? Do we deliver through fixed points, or do we deliver these vaccines through different channels? Or as the pandemic stabilizes and countries begin to move, many countries, I suppose, begin to move the COVID-19 vaccine programs from, vertical programs and integrate them into immunization programs. How efficient can we be? So these systems, these questions related to the health system are important. They have typically not been addressed mainly by, the kind of economics we know, but it is something that we at Africa CDC are keen on pushing. And when I talked about, so that's contextualization. But also when I talked about elevating the public health emergency surveillance, they are systems issues, right? So we need to first build capacity around, economics, apply economics to this, but also take urgent steps. And there are indeed a list of activities that we've planned to undertake in this regard.
Thanks, Chris. You're next.
Great, thank you
Douglas.
very much for the talk. I'm wondering on the building local capacity. Given there's over 50 countries in Africa, I was wondering the process of how Africa CDC selects or approaches the many different countries in the region, and how, you know, their COVID response and also their local capacity. So how does Africa CDC sort of branch to cover those many different aspects?
Yeah, thank you very much. So I'll give you an example and I'll come back to that. So the Africa CDC right now, the Africa CDC's vaccination program, what we call the Saving Lives and Livelihoods program, is actually working with countries to strengthen their vaccine rollout strategies. And I think currently we are working in more than half of African countries, but incrementally. And what Africa CDC is doing is working with a wide network of stakeholders, but being more or less leading the process to ensure that, of course, Africa CDC is a creation of countries, right? So it has the mandate to do that, but more essentially working with different stakeholders. And I think the Africa CDC has been successful in doing that. What the Health Economics Program is seeking to do, indeed, if you think about it, there are not, for instance, so many academic institutions in Africa that actually run health economics programs. There are not so many. So what the CDC typically is doing actually is having conversations. We've already begun the process, of having conversations with, groups of stakeholders. If it has to do with academic group, we've had meetings with the different institutions in Africa that run health economics programs, graduate programs, master's, PhD. And essentially we are agreeing together with them how best we can develop a framework to help do this. So we are taking first of all, a regional perspective to this. Regional means that it is better to be specific, but also it is better to pull together the resources at the regional level. We know that some countries, for instance, have a lot of health economics capacity than others. How can we leverage on these different pieces? We also know that there are many academic institutions, for example, both on the continent and outside the continent. I mean, we know Harvard does a lot of things in different places. We know Stefan's group and Bergen have done a lot in Ethiopia, for instance. We know London School has done a lot in specific countries. So it is essentially about agreeing the framework of doing these different things. The role of the CDC is really facilitating the process. Not only the hardcore short-term training, longer-term trainings, but also mentoring. And what I did not say about the Africa CDC, which I'll say now, is that the Africa CDC is not just that CDC sitting in Addis, but it has regional centers. So in each of the AU regions, there are regional centers, and there's a network of national public health institutes within countries. So we are working with the different levels, and for us, it's about creating that framework together with these different entities. We're already having conversation how we can sustainably strengthen capacity. Of course, we need to start from somewhere, but first we need to identify what capacity exists, and those are different ways that we are doing that. And yeah, we open our arms to every stakeholder that is seeking to do something, so that we ensure that this is sustainably done. Because we do know that there are many entities that seek to build or claim to build capacity, but eventually, leaves very little trace of capacity on the continent. So we are seeking to essentially bring sustainability to that by engaging all the stakeholders.
Great. Douglas, you had your hand up, I saw. did you have a question, or otherwise we go to Michael? Michael, then?
Hello.
Thank you, Stefan. Oops. Thank you. Thank you, Justice, for the wonderful presentation. And thank you also for your participation in the special issue on strategic purchasing that's coming out in Health Systems and Reform. So I wanted to ask you if health economics, as you've described it at the CDC, also considers questions of political economy. And if it's not part of health economics, is it a separate program at the African CDC? And where do you see political economy for health in Africa?
Michael, thank you very much. And I'm happy you asked this question. A couple of hours ago, I was actually teaching Stefan's class, and I was telling them, indeed, today's lecture focused on political economy. For
Yes,
priority
Michael.
setting, pulling up one of your frameworks, that identify the different things. And indeed, we've used your framework. I think that, okay. When people think about Africa CDC, first and foremost, they think about that entity that only focuses on disease prevention and control, laboratory systems. That's it. What we are seeking to do at Africa CDC is to say, yes, as a health economics program, we are helping Africa CDC do these different things, but incrementally looking at the different aspects, because the reason we call it health economics is to accommodate the different things. But indeed, political economy, one cannot dissociate, or one cannot, political economy from, the different things we do under health economics. Priority setting. Because when I talked about contextualization, you contextualize what you clearly understand. You know who the stakeholders are, what the different interests are, and you know how to engage the stakeholders, and it's interesting. So the program and the CDC are sitting more at the policy side, right? And we are working with other stakeholders, But at the policy side, we know that all these issues of bureaucratic politics, all these issues of budgets, that really are not very simple issues, as far as the political economy are concerned. So we are even more concerned, and I think we are taking an incremental approach to that. It's a matter of carrying capacity, but essentially we are not. I only give examples on work we are doing now, but even within that work, in engaging stakeholders to identify the policy questions, we very much are interested in what is happening in the political economic space. So just a long way of saying that, yes, Michael, we think that political economy, but also other aspects of economics are important in this space. And even though we call it a health economics program, we actually, would consider the different aspects of things as far as they all hinge on prioritization, which is the key thing we are trying to address.
Good.
Great.
Well, anything I can do to help, I'm happy to do so, Justice, as you move forward in this space.
Thank you very much. And I will reach out. Thank you.
Great, thanks, Michael. Douglas, I think you wanted to ask a question to Justice.
Yeah, hello, Professor. That's a great presentation and a good effort by the CDC. I would want to ask, these health evaluation tools, are these tools considering the vulnerable groups? Because when you take into consideration some of these tools, like for instance, the cost-effective analysis and the cost utility tools, those assessment tools, you realize that always it doesn't consider some of these vulnerable populations, like the people with mental disabilities, people who are having that disabilities. So how are we going to factor this in these tools development, and also the social determinants? Because I know they are key things when in terms of improving population health. The social determinants are key things that we can't let go. So how are we factoring in some of these things to engage the stakeholders and the rest from these disability groups to make inputs to improve the existing tools?
Yeah, thank you very much. I think your question borders on some of what Michael asked, the political economy, but also maybe Stefan is in a better position. Stefan is this guy who led the charge on extended cost effectiveness analysis that basically takes the cost effectiveness. We know, you estimate a ratio that is just 1, but actually you bring in equity considerations. And by equity, you look at the different groups, you look at the different groups and how you are not just presenting one ratio that focuses on, and that's an average ratio really, but accounting for the different teams within that. I do know that there are other groups within the African Union that do a lot of the engagements with different groups. I mean, the African Union Commission has a lot of work with, really bringing these different vulnerable groups together. At the CDC, we may not necessarily directly engage these different groups in what we do, but we actually bring perspective to what we do, to these different vulnerabilities in terms of whatever we do, but also in terms of engaging. When we engage policymakers, we are not only engaging on average issues, we are actually considering all the inequities and the vulnerable groups and the different things that are concerned. So I think that's also important.
Excellent. Okay, thumbs up, Douglas. Great. Any other? We have 5 more minutes until the hour. Any more questions or comments, reactions for Justice? Okay. I don't see any hands up. So let us thank Justice very much. Thank you very much again, Justice, for really a great overview of some of the ongoing work you're taking on at ACDC and some of the challenges. Thank you very much. Oh, I see Dan has his hand up. I think we can. I'm sorry. I think we can wrap up here. Sorry for the confusion. Thank you very much, Justice, for a great talk. And see you soon.
Thank you.
Bye-bye.
Thank you. Bye.